Hello, everyone. My name is Dr. Vishesh Khanna, and I'm an incoming assistant professor of oncology at Oregon Health and Science University. I have the pleasure to be joined today by Dr. Jonathan Rosenberg from Memorial Sloan Kettering Cancer Center. Dr. Rosenberg, thank you so much for taking the time to join us this evening.
My pleasure.
So we just had a panel discussing the current and latest updates in bladder cancer management, and I was hoping for our listeners, what do you think are the two sort of key takeaways with recent advancements in bladder cancers that us in the community should know about?
It's a great question. So I think the most important breakthrough in the last 25 years has been the use of enfortumab, vedotin, and pembrolizumab in metastatic disease. It has blown chemotherapy out of the water, doubling overall survival, progression-free survival, complete response rate about 30%, and really has changed how we treat this disease. I think also the other important thing that's coming and is here is the use of early checkpoint inhibition in the perioperative setting, either pre and post with durvalumab and chemotherapy or adjuvant immune checkpoint blockade, where we're hoping we're curing more patients, and that's really what the goal is.
Fantastic. And one of the things that has recently come up with some of these new impressive data on perioperative immunotherapy in addition to chemotherapy is what happens to patients who may eventually have recurrent disease. Are they receiving EV plus pembro at that time, or are we switching to a chemotherapy backbone? What's your practice like for these patients?
It's a great question that we don't have a good answer for at the moment. Patients who progress during checkpoint inhibition probably don't benefit that much from continuing it. And then the question is, do you switch to enfortumab or do you give chemotherapy? It's an easy answer if someone's had neoadjuvant chemotherapy, right? And then adjuvant checkpoint inhibition. Well, you're going to move on to something like enfortumab. If they've been off immunotherapy for a period of time, it makes sense to give the combination of EV and pembro. If they've progressed during immunotherapy, I don't know what to, like I can't say I have a consistent practice. Then it's talking with the patient, trying to understand what they want, what the toxicities are going to be for that patient. Platinum-based chemotherapy is very reasonable. Switching to EV monotherapy is reasonable. Doing EV pembro is reasonable, but may not be any better than EV alone.
Understood. Thank you for that. One of the other important things that I think has come up with recent data is just how far are we willing to push the GFR limit for cisplatin in cisplatin-eligible patients. And I'm curious if you could just walk through in a couple minutes where the field used to be in terms of what was considered cisplatin eligible and what some recent data have shown us as far as what could be permissible for such patients.
Right. So from a sort of field perspective, 10 or 15 years ago, a group of us got together to define cisplatin ineligibility in order to facilitate clinical trials. And in that effort, the cutoff based on expert opinion and community opinion was a GFR of 60. But all of us who've been treating bladder cancer know that by splitting the cisplatin 50% the first week, 50% the second week in GemCis regimen, or day 2 and 3 with Docetaxel, or day 1 and 2 with Docetaxel, that you can get away with GFRs down into certainly down to 50. And now we see gemcitabine, cisplatin, durvalumab down to about 40. Some patients will develop more worsening renal insufficiency in that scenario, and you do have to be careful and monitor things very closely. And if you see a decrement in renal function with split dose cisplatin gemcitabine in the neoadjuvant setting, you bail and you go to surgery rather than try to switch to carboplatin, for example. So you need a fair amount of fluids, but to do that with patients, but you can get away with it. I'm very comfortable going down to 50, even into the high 40s. I haven't done a lot with down to 40, but other people have and feel comfortable with it. It may be, though, that this question becomes moot over the next several years because the EV303 and 304 trials are perioperative enfortumab and pembrolizumab. And if those are positive, which they're likely to be positive based on the metastatic data, then we're going to remove the cisplatin eligibility question completely from early stage disease, in which case it may still be an issue later on, but not in the neoadjuvant setting.
Thank you for that. And as my last question goes, what are you most excited about in the year or two to come in the space of bladder cancer?
I think there's a few really interesting things. So first, One is the potential sequential use of Nectin-4 targeted therapy with new ADCs that are being tested with different cytotoxics that may have different, that might be non-cross resistant in terms of the anti-tumor activity, and also having different toxicities. And then the other thing I think is very interesting is the two other things interesting. One is Nectin-4 directed radioconjugates, which are probably coming to a trial near you. And then the FGFR3 specific inhibitors, rather than the pan-FGFR inhibitors for FGFR3 mutated disease, because a lot, but not all of the toxicity we see with those drugs is from FGFR1 and 2 inhibition and 4. And the FGFR3 specific inhibitors are probably going to have a much better toxicity profile, and it'll be a lot easier to keep patients on FGFR inhibition. And so I'm very excited to see where those pan out. And at this meeting, we're going to see some data from LOXO 435 and get a sense of where this field might be heading.
Wonderful. Thank you so much for your time, Dr.
My pleasure.
Rosenberg.
Pleasure.
And again, I'm Dr. Vishesh Khanna, and this has been an Advancements in Oncology session hosted by the Oncology Brothers. Thank you for joining us.